So thank you very much for asking me here today. Can everybody hear me? Yep. I'm losing my voice, so I'm glad I'm talking at 10 a.m. and not close of play. So if at any stage you don't hear me clearly, please let me know. So I'm going to hopefully set the scene today for there's some amazing talks to follow covering every aspect of menopause. We've been told to keep strictly to time, so I'm very happy to take questions at the end if we have time. If not, please come and join me on my stand, Gynae Expert. We've got a large stand in the middle of the room, and delighted to speak to you if you have any questions after. And I'm also holding a couple of breakout sessions up in room C later on. So please come and join us. So firstly, who am I? I thought I'd just give you a quick summary about my career to date and why I've been invited here today. So I've been practicing menopause for 30 years plus. I was very fortunate to be able to do postnatal and premenstrual research as well as menopausal research with John Studd when I was a junior trainee. And that just fueled my enthusiasm for hormonal problems. And I've run menopause clinics throughout my whole career, through the NHS and also privately. A few years ago, during the pandemic, we opened the Amara Clinic because I wanted to be able to deliver the highest level of service, and I was struggling within the confines of the NHS. It's a common problem, and we have the luxury of time when we're speaking to our patients, which unfortunately one doesn't have in the NHS. I'm one of only 200 or so advanced British Menopause Society specialists, so we've all done a much higher level of training. We have a higher level of expertise. Most of us have run menopause clinics and still do. And we are hopefully going to be rolling out training throughout the country in the years to come. In addition to my clinical work, I also do some medical legal work, and I'm regularly involved in speaking at educational events like this, and also to employers. So I have a very widespread career. And a few years ago, I published a book, Natural Menopause, with Dorling Kindersley, and that really is the basis for my the ethos that we practice at the clinic. It's very holistic. We're not just focused on HRT. We offer a wide range of services, and I'm delighted to see that several of the talkers after me are actually covering the holistic approach to menopause, because I think that's really important. I wouldn't want anybody to simply think that HRT is the answer to everything. So the clinic is set in the centre of Tunbridge Wells. We're very accessible, and I work with a wonderful team of GPs who also practice in the NHS as well. So it's a very female-centric clinic, and we all love the environment that we work in and the job that we do. So the role here today, as it is with the patients we see, is to educate, enlighten and empower. And I would say anybody starting on their menopause journey needs to have that education to be able to take the most from any consultations they have, whether it's with a specialist like myself or with a GP or a practice nurse. You really need to self-educate as best you can so that you have an idea about the sort of journey that you want to follow. As I said, there's no one-size-fits-all, and the sort of platform that we outline in my book covers a wide church. We talk about complementary therapies, herbal therapies, fitness, nutrition, mental well-being. And it's really important that you're aware of how each of these aspects fits into your perimenopausal journey. This is the 6 pillars that we follow in the clinic and in the book. And I think it pretty much covers everything that you might want to look at during your menopause journey. And patients will definitely get the best if they look at all 6 pillars. It's not just about focusing on one to the exclusion of everything else, particularly HRT. I mean, obviously, I'm a huge advocate for HRT, but for some women, it's not the answer, or there might be medical reasons they can't take HRT, so you need to look at the bigger picture. So before we start to talk a little bit about biology, I thought I'd just give you some quotes from patients. These are from emails and letters that we've been sent, and these are very typical comments. I always say if I had £1 for every time a patient said to me, I'm just not me anymore, or I've lost myself, I'm not the old me I used to be, what can I do? I'd be very wealthy. It's one of the commonest comments that we see. And again, women, you're often not looking just at one particular symptom, but they're looking at the combination of vasomotor symptoms plus insomnia, plus the mental torment that some women go through, which is beautifully outlined in this slide here. This was part of a much longer email we got from a new patient who was nearly 10 years on from her menopause, but still suffering from symptoms in her mid-50s. It had affected her work, it had affected her relationships, her mental well-being, her physical well-being. Women like this often think that they might even have early onset Alzheimer's because the symptoms are so severe. So although these seem very aggravated statements, they're actually very realistic, and many women do suffer to this extent, and it can go on for many years. So what actually happens at menopause? So menopause is derived from Latin for last menstrual period. And at that stage, the ovaries stop working. There are no more eggs left. It's a gradual process. Perimenopause generally starts from 45 onwards, but in some women it can start much earlier, late 30s, early 40s. And as the ovaries are winding down, there's an equivalent reduction in estrogen and progesterone and testosterone. Now, estrogen is the main hormone that everybody talks about, but progesterone and testosterone can be important. They can be a key part of the equation as well. And if you're on a well-balanced regime, those hormones will also be included, although the main focus is always on estrogen. Estrogen levels decline gradually, and the net result is that just before 52, most women in the developed world will become menopausal. It can be earlier if you have a family history, and there will be a talk later on premature ovarian insufficiency, which is the term for premature or early menopause. And some women may have a later menopause in their late 50s, often genetically driven. But the average in the UK is 51.7. And you might say, well, why is there so much interest in menopause around this time? And you see here, women will now spend more than a third of their living adult lives beyond menopause. The life expectancy over the last generation has increased dramatically. And women now are expected to be, leading busy lives. Many women are working in their 50s, 60s, and sometimes beyond. So, physical, mental health and emotional health is very important. And I'm sure that's one of the big drivers for the interest in menopause support and HRT nowadays. It perhaps wasn't there for the previous generation. And this graph shows beautifully the rise in life expectancy after the Second World War in particular, but it's been a gradual rise for many generations. And 15% of women are not going to get over menopausal symptoms. You might say, well, give it a year or two and I'll be fine. But studies have shown that as many as 15% will still be experiencing symptoms in their 60s, 70s and beyond. And again, that is usually a genetic feature, as is the timing for menopause. So if you want to know what your menopause is going to be like, it's a good idea to look at your mum, your gran, any female relatives, because it may well be very similar. And this slide is just a summary of the short-term symptoms that we see women coming with. Obviously, there are physical symptoms, emotional, cognitive, menstrual, but there are also longer-term concerns that more and more women are now coming forward with. Even women who have relatively few symptoms are aware that they need to be concerned about cardiovascular health. They need to be thinking, am I going to get dementia, Alzheimer's dementia, any other neurodegenerative diseases? What's my risk of osteoporosis? And we know that the vast majority of these long-term conditions do respond to preventative long-term HRT. So I think there needs to be a balance between my short-term control of symptoms, whether that's for 5 or 10 years, and then looking at longer-term health way beyond menopause. What's your health going to be like in your 70s, 80s and beyond? And women are much more focused at that, the bigger picture, if you like. So I just want to focus on the commonest group of referral symptoms that we see. It isn't flushes and sweats, which you might expect it would be. It's actually the cognitive, psychological and emotional bundle of symptoms that women experience. And these are listed here. We've got severe anxiety, often global anxiety, which is not about a specific event or a specific worry. It's a more global phenomenon about every aspect of life. And that can lead to panic attacks in severe cases. It can be associated with palpitations, and it can feel like a very physical phenomenon. We also see far higher instances of low mood, even clinical depression, sleep disturbance, which of course is linked with mood disturbance, cognition, otherwise known as brain fog, with reduced short-term memory, focus and concentration. And these all happen because the central nervous system has very dense areas with estrogen receptors present. Estrogen is very much seen as the conductor of the orchestra, and that's why we know women can multitask generally and men can't. It's estrogen that controls that function. So if you're used to being somebody who can answer the phone and answer the front door and speak to somebody and do an email all at the same time, that's because of the estrogen conducting those parts of the brain. And as you hit menopause, perimenopause and so on, the estrogen levels decline, and that's when you start to notice that you're no longer as agile and as productive as you were before. So you may have seen recently in the last week, there's been a huge coverage of the new NICE guidance. As I've said here, the revision is due next year, and the document for review is circulating amongst stakeholders like myself at the moment. So I think there will be some dramatic changes to come out to the guidelines next year. So it's a very exciting year to come. And that will be almost the 10th year anniversary of the NICE guidance, which was first published in 2015, November 2015. And it set out an amazing vision. It's great to have a vision. It's great to have a mission statement. And here we have a really comprehensive statement saying, menopause is a life journey affecting all women who reach menopausal age. There's a vision here about having access to accurate, up-to-date information. Doesn't have to be from a specialist like myself. It could be from anybody with a good basic training in menopause. That could be a nurse practitioner, it could be a GP, it could be a lay person who's been trained. And then that person should be able to direct you to support you on your journey, whether you need higher level advice from a specialist like myself or not. And I think this is still here in 2023, this is still an amazing vision, but unfortunately we're struggling to roll this out because of training and education issues. And that's why I'm so passionate about events like this, not just for the lay public, but also to train as many GPs as we can and practice nurses as well, because we need staff to roll out education, treatment, and to signpost women effectively. And sadly, for too long, menopause has been completely disregarded. When I came through medical school, it was entirely optional. And until very recently, most doctors would qualify without any formal menopause training at all. You would never attend a menopause clinic. You may never even attend a menopause lecture. And yet, when you're qualified as a GP, you would be then expected to take part in treating perimenopausal and menopausal women. And I think that's a huge part of the explanation as to why there has been a definite problem with menopause treatment over the last decades, since the 1990s. So you can see here we've got 13.5 million peri and postmenopausal women, and there are around 200 fully accredited specialists like myself. And you would not see that in any other area in medicine. You wouldn't see that in diabetes or epilepsy or any other major condition. So, that's just testament to how little regard, unfortunately, has been shown for menopause training and education. Now, it has changed, but, it will take time for those doctors and nurses to come through with adequate training to be able to help women navigate their menopause journey. What I thought I'd do is, before we talk a bit more about hormones, we'll just do a bit of myth busting. And of course, the big one, the zombie theory, is breast cancer. And I hope if you take one thing away today, it will be that you should not worry about breast cancer, because the modern HRT regimes are incredibly safe. I would say women today have never had it so good, as long as they are on body identical hormones, which we will come on to towards the end of my talk. And this is just it's a very busy slide, so apologies if you can't see it. But this is a slide that raised the furore in the 2000s, when everybody suddenly stopped HRT overnight. So we see here that in those days, women on conventional HRT would have an additional 4 chances per 1,000 with long-term HRT use of developing breast cancer. So 15 women per 1,000 would develop it, an extra 4 on long-term HRT. But the difference nowadays is we do not use these types of HRT. This relates to HRT with synthetic progestogens, and we know that those were the main cause of the increased risk in breast cancer, not estrogen. It's the progestogen that we need to focus on, and we'll come back to that. So don't believe everything you read in the media, I would say, about breast cancer, because a lot of it is misreported. And another controversy, many women are told if they've had a thrombosis or a clot, blood clot, or family members have had an event, they can't have HRT. That's not the case. If you take your estrogen through the skin, you absolutely can. Cardiovascular risk, women used to be told it'll give you heart disease if you take HRT. Again, all the studies over the years show the reverse is true. HRT actually reduces the risk of cardiovascular disease, so that's heart attacks and strokes, if you start it early enough and if you take it for long enough. So again, that's another myth. And even if you have heart disease, you have high cholesterol, you have high blood pressure, there's absolutely no barrier to having HRT. So it's really important that whilst you're navigating your menopause journey, that you are aware that a lot of the myths that you may come across are untrue, and there are really very few contraindications to taking HRT. And this again is a very important slide. Take home the fact that if you're on long-term HRT, your overall risk of dying is reduced by 40% compared to age-matched women who are not on HRT. And that's because of the reduction in cardiovascular disease, the reduction in osteoporosis, and the reduction in other causes of mortality. Even bowel cancer is reduced on HRT. So we've got this huge range of benefits, top to toe: better mental health, better bone health, better cardiovascular health, better bladder health, you name it, it's there. I mean, we could spend the whole talk just covering the benefits of HRT, and these are all scientifically proven. It's not just me standing here saying it's wonderful. These are all scientifically proven benefits. So, as I say, don't believe the myth. The science says otherwise. So, what do we mean by body and bioidentical hormones? So, Body identical hormones are what specialists like myself prescribe, and we're going to talk about those in more detail. Don't be confused with bioidentical hormones, which are unregulated. They're not subject to scientific scrutiny, and they're not recommended or supported by the British Menopause Society. So they sound very similar, but they could not be more different. And there is very good information on the British Menopause Society website regarding the differences if you want to look further. So these are the hormones that women should be on. If it's a body identical estrogen, it has to be given through the skin or under the skin. You can't give body identical estrogen orally. Body identical progesterone, which is the game changer, that has made the biggest difference to menopause outcomes, breast cancer risk over the last few years. So these are the gold standard. Body identical progesterone, otherwise known as utrogestan, and body identical estrogen, which can be given through the skin as a patch, gel or spray. So if you're on anything other than those, it's not body identical, almost certainly. And just be aware as well that some patches are not purely body identical because they contain synthetic progestogen in the patch. So that would be patches such as Everel Conti and Sequi. So all patches are not equal. So it's very important that you know exactly what you're taking and the risks associated with that. And this is why transdermal estrogen is so safe. It bypasses the liver, so you don't get the impact that tablets have on the risk of high blood pressure, thrombosis and clots. And it's much easier to adjust in terms of doses because you can adjust the dose of patch and spray very easily, so you can get a great outcome with very little adjustment. So body identical is the way to go. One of the products that we have on our stand with us, if you want to come and see what the Lenzetto's like, it's the newest transdermal spray. It's a fantastic product, very easy to adjust the dose, very discreet. You just spray it on your forearm, much easier than the gel, which takes ages to dry. But come and see it if you're interested. And here we have the game changer. This is the biggest development in HRT, certainly in my career. Body identical progesterone, which does not increase the risk of breast cancer for at least the first 5 years of treatment. There is no other progesterone that we can say that about. So again, the risk of HRT depends very much on what you're taking. And you should be asking whoever's prescribing you, am I on a body identical regime? And if not, why not? And challenge them, ask them, what do you think about the risk of breast cancer? Why are you not putting me on a body identical regime? And that's why education is important, because then when you go to your consultation, you can actually challenge the specialist with this information. So, huge change, modern HRT management. This is what we should be thinking about when we're prescribing. We should be following the guidelines, obviously. We should be using body identical hormones. We should be looking at the bigger picture, not just treating for a year or two, but what are the long-term benefits of HRT in terms of cardiovascular health, neurodegenerative disease, bone health. Should we be treating to 60, or should we be treating beyond? Should we be treating earlier during the 40s? These are great questions for debate, and evidence suggests very much so that there is not a barrier to treatment that's dependent on age. So you can't start too young and you can't finish too old. So again, to close the loop and go back to the idea of holistic care, we're not just focused on HRT. And if you look at all these other aspects of health, particularly fitness, strength training, dietary intake, nutritional support, there's no question that you're going to get the best out of your HRT regime. And we stress that when we're seeing patients in my clinic. There's no one size fits all. And just to sum up the influence of lifestyle factors, this shows very clearly the impact that alcohol intake, even moderate obesity, has on the risk of breast cancer. So instead of worrying about the impact that HRT will have on the risk of breast cancer, we should be looking at these modifiable factors, which have a far more vast impact on breast cancer risk than HRT ever did. Even 2 units of alcohol a day will have a dramatic increase in the risk of breast cancer, as will having a BMI of 27 and above. I think there's a lot of modifiable targets that women can focus on that will have huge improvements in their long-term cancer risk, rather than just focusing on the HRT myth. So, for those of you who want any more information, the British Menopause Society is a fantastic resource. They have a great website. You don't need to be a member. They have a menopause map, which you can Google, and it has details of all the regulated menopause clinics in the country, private and NHS. You just put your postcode in, and it will tell you the details of each and every menopause clinic close to you. So if you want to take advantage, that's a very good starting point. Thank you very much.